Hello everybody, I'm going to talk about graduate entry in nursing, and then my colleague Caroline is going to talk about graduate entry in the allied healthcare. Just before we actually go into some of the nuts and bolts of graduate entry in nursing, I'm just going to take you on a little, very brief history or evolution, a recent evolution of nurse education in Ireland. What I was going to say is that many of you here in front of me probably trained like I did, because I thought there might be a lot more nurses here in front of me that I'd recognise, in the old apprenticeship model. And that model was you did 3 years, you were part of the workforce on the floor, the schools of nursing were based within the hospital, and you were an employee. And what that meant was that a lot of the focus of that education was actually on making sure that the wards were well staffed and the work was done. The needs of the learner were never to the fore. That changed, thankfully, in 1994, when we had the changeover to the Diploma of Nursing. The Diploma in Nursing. And Galway actually was the first university nationally to introduce that programme. We then had, in 2002, the introduction of the 4-year degree, and that led to the first graduates in 2006. And since then, there's an established evidence right across the board that in any given clinical setting, when you have a higher proportion of registered nurses who are educated at degree level, the patient outcomes are far improved. So the evidence is very much there to support that pathway and those changes. Now, going back to what I came to talk about. In terms of graduate entry, it's been around actually for quite a long time. And it's in many countries. It's in the UK, New Zealand, with the first graduate entry programme in 1974. Now, graduate entry means a pre-registration programme for individuals who actually already have a level 8 degree programme. So it's a route for them to enter the registration of the nursing profession. Until now, there hasn't been that much appetite for graduate nursing in Ireland, and I know we've looked at it previously. My previous head of school sitting here in front of me down here looked at this a couple of years ago, but actually the appetite wasn't there. So why now? And that's why we have this quizzical little child here looking. Why now? Why are we looking at it now? So some of the driving forces, I guess, and a lot of them have been mentioned today already, in terms of one of the key the global shortages of nurses for the effective functioning of the health services. As some of the colleagues already this morning, and even again Paul Hooton, Chief Nurse, have mentioned, we're the largest number of profession within the healthcare setting. In 2020, pre-pandemic, the WHO estimated there was a shortage of 5.9 million nurses. More recently, the International Council of Nursing have actually said this shortfall is now 13 million. And the reason for the big difference and the growth of this problem is obviously there was a pre-existing shortage. We also have what's called the greying of the population. People who we look after as nurses, we are living longer, which is wonderful, but people are living longer with more chronic conditions. You also have the greying of the actual nursing population, so more of us are retiring. And the estimated from the ICN is that the potential of people who actually will be leaving the profession in the next 15 years will actually be about 2.5 million. 10% of people will be leaving the profession. Ireland also has a problem, and obviously that has been related to today again by numerous speakers. And if we look at the moment from a recent report that just came out there in September from the Minister for Health, that they predict that domestically educated nurses will fall from 54% to 38% over the next 20 years. That's quite significant if current trends actually continue. And that relates to something that Paul Hooton said just shortly there in his talk, was that the push therefore is actually to increase, and the Minister wants us to double the numbers that we're educating every year. And there's about 2,000 coming out every year, but they want us to double it now going forward for the next year to try and cope with some of these shortages. The other driver is ethical recruitment. 89% of the shortfall in low and middle income countries is happening, and part of the reasoning for that is that the wealthier countries are actually recruiting from lower income countries. 1 in 8 nurses work in a country other than where they were born or educated, according to the WHO. And in Ireland, approximately nearly half, 47% of nurses are educated outside of Ireland. And Ireland has signed up to the WHO global conduct of ethically recruiting healthcare professionals, which is a push in another direction, meaning that we need to look at growing our own, as people used the phrase this morning. Retention is another driving factor, and again, this has been mentioned this morning. Across the world, we're failing to retain and keep our health professionals, our nurses within the system, and that's due to work overload, lack of support, high levels of burnout, and that has increased significantly post-COVID, because nurses at the front line during COVID, not only do they have personal stressors about working in the environment, facing infection control, worrying about going to work in the morning, there was also system pressures where you could be redeployed to a different area that you may not have worked in, and people put their shoulder to the wheel, and they did that. But people can only be resilient for so long, and that catches up. And we're seeing that now. It's not just in Ireland, it's across the globe. And the final driver, I suppose I'll mention today, again as mentioned, is the whole transformational changes that are taking place within the health services. We have, as people have already said, the 6 regional healthcare areas paving the way for FutureCare, and the FutureCare implementation strategy, which I suppose is our innovation. When Michael this morning was talking about we need to be innovative and we need to look at how we make the changes, then this is one of our changes. And some of the things that people were mentioning, like Emer, Ciara and Michelle before lunch, integrated care, enhanced community care, digital health, these are all the transformational changes that are coming online now within the services. And we need, to take on these transformative changes, we need to focus on care that's enabling patients to manage chronic conditions and integrate new technologies. And we need more nurses, more well-educated nurses to degree level to help to implement this and these changes. And that's why we look at graduate entry. Graduates come with academic ability, they come with transferable skills, they can analyse, they can present information, they know how to learn, they already have an expertise in a pre-existing discipline, and they're highly motivated. This is coming from evidence across other countries. The other issue is that 90% of the nursing working force actually are female, which is no surprise, I think, to most people. But what is a surprise is that there's evidence now emerging that graduate entry may be a route that actually is very attractive for male nurses, rather than the traditional route. And as somebody said, mentioned earlier, the nurses who are graduate entries have made a really commitment, have made really taken the time to think about the route, and they're much more likely to stay within the profession. So what is the timescale and what needs to be done? And this is really kind of an image of me thinking, oh my God, how are we going to manage this within the timescale? Because the goal is to have graduate entrance within 18 months. And NMBI will have the standards and requirements end of November, hopefully. The curriculum will then be developed within 12 months because we get through the usual processes. And I suppose I was smiling to myself this morning when Michael was saying about, we need to shake things up and we need to challenge the bureaucracy and all of that. And I'm here thinking, I need to talk to somebody about moving some of the quality assurance mechanisms, deadlines that we have within our university to help us to get this over the line. The recognition of prior learning will be really important because at the moment the thinking is, and we don't have the final standards and requirements, the thinking is that 20% of the programme from their level 8 will actually can be accounted for in the graduate entry system. So that we will have to have a system put in place that's fair and transparent and equitable across all sites that are offering these programmes, and that's going to take time. Additional clinical placements, as Paul Hooton mentioned, is something that needs to be identified, and a recruitment strategy needs to be developed and implemented. For our school and college, we need to look at things as well in terms of teaching. The way you teach mature students is different, so a much more focus on inquiry-based learning and experiential learning. We also don't know whether this programme is going to be tendered or not, and that will have implications for us and the college. The programme is expected to be 98.5 weeks duration, and therefore that will mean the programme will be delivered outside of the traditional academic route. It will be a calendar entry. And staff will have to teach and run the programme then during outside of the standard academic year. That has its implications. The implications also are that students won't have the opportunity then to actually earn during the summer as our current students do? And will that have implications for recruitment? Recruitment may be challenging. We actually don't know what the interest is out there. We've nothing to tell us how many people are actually going to take on the programme. So you're putting a lot of investment in a programme and we're not quite sure what the uptake will be. Space and infrastructure and staffing levels will need to be looked at. And we will need to look at and negotiate the fees to cover some of these issues. For the college, though, there is, and for us in the school, there are a lot of opportunities and a lot of reasons to be optimistic for bringing in this programme. It responds to the clinical partners' critical need for staff and also the world shortages, obviously. It creates, for us, the opportunity to create academic career pathways for these cohorts, so further training down the line, more PhDs. Further differentiates us between the universities, and Michael was saying this morning, you know, that good to have competitors. It makes you, you know, much more on the game, and you know, if you don't do it, somebody else is going to do it. So it's again, it's a way that we could be leading the field here, given the changing landscape at the moment, in terms of we have technological universities and we have, I was going to say ordinary universities, but universities like University of Galway, and there also is a huge potential for highly engaged, highly motivated students. So here's the happy face. Graduate entry will not solve all the problems. I'm not saying that it will, but it can and it should be part of the solution. Thank you.
Thank you. Thank you, Professor Dympna Casey. And Professor Caroline McIntosh is now going to say a few words.
Thanks, everybody. Just following on from Dympna's talk, I'm just going to talk to you a little bit about graduate entry programs in the health and social care professions. But bear with me, because I'm going to do it in a little bit of a long-winded way, not too long. But over recent years, we've all heard from various speakers across today, and we've had some excellent speakers there this morning. The health services have faced really considerable pressures. We've heard about the workforce shortages. We've heard about the ageing population that we face, and with that, increasing comorbidities and various diseases that need to be managed. That's going to lead to increased healthcare costs. And then, of course, we've all lived through the last few years of COVID-19. So in response, health services in lots of different countries have focused on transforming the workforce, really to enhance service provision, and we've learned a lot through COVID-19 and crossing boundaries and changing roles and shifting priorities. And really, I think we can do more, as we've heard today, in terms of FutureCare, in establishing innovative care models and developing more advanced roles so that we can truly see workforce transformation. In 2017, Health Education in England published the Multi-Professional Framework for Advanced Clinical Practice. And this aims to give clarity on what is advanced practice and examples of good governance, and thus enabling employers, including the NHS, to develop, enhance and deploy advanced clinical practice within their organisations. And they've based it on 4 pillars. So that's clinical, education, management and leadership, and research. These are the health and social care professions. So this is a diagram from the Health and Social Care Professions Office. It's not fully inclusive of all the different allied health professions and social care professions that are out there, but it gives a flavour. And in researching graduate entry programs, there's very little literature on any of the allied health and social care professions. The literature is largely predominated by nursing graduate entry programs. That's not to say they're not in existence. They are in other countries, and in this country indeed, for instance in areas of OT and speech and language therapy in other universities. So just thinking about the pillars of advanced practice for clinical practice, an advanced care practitioner is somebody who can prevent a person from being referred on to lots of different multiple services. So if they see the right person at the right time and get an early diagnosis, they can often be managed by that person who's correctly skilled to do so, thus enhancing the patient experience. They can also take on traditional work, so particularly advanced practitioners in the areas of health and social care can take on the role of consultant doctors, reducing their workload and waiting times while influencing and transforming the health services. We embed advanced care practitioners in some professions, which puts them in a good position to contribute to that workforce transformation, more innovative ways of working, and new models of care. With that is leadership and management, and we've heard about the importance of good leadership throughout the morning session. So the priorities for advanced care, health and social care practitioners is to meet the changing needs of the health service through strong leadership, through further development, evaluating improvements and the impact of their contribution. So advanced care, health and social care professionals, we heard about autonomy and the importance of autonomy in keeping people satisfied in their job role and for retention of the workforce. It's really important. So allied health professions really need to be equipped with that autonomy so that they can act as role models, provide mentorship and support others to reach their full potential. So getting on to education, absolutely an important aspect of advanced care practice is the acquisition of specialist skills and knowledge for these individuals who will be clinical leaders and education providers of the future. As a university, we need to be able to respond flexibly to those changing requirements and to service transformation and work very closely with our healthcare partners in order to realise new, more innovative models of care. And that requires a really good working partnership. The last pillar is research, so thinking about research as a driver for change, to monitor and improve standards, to prove, I suppose, in terms of advanced practitioners in health and social care professions, our worth in terms of what we can achieve in improving patient outcomes and improving delivery of service. So why graduate entry? Graduate entry gives us the option to train high caliber, highly competent health and social care professions to a level 9. So whilst it's a pre-registration course, these individuals come to us with a level 8 qualification. So we can graduate them at a level 9 with an element of more advanced high-level skills to equip them to have a more accelerated route to become those advanced care practitioners of the future, to become managers and to become future leaders. Graduates exiting from a level 9 program would be able to deal with complexity, reason at an advanced level, demonstrate high levels of clinical judgment, critical analysis, and advanced decision-making, promote and demonstrate best practice by integrating evidence into their practice. And the graduate entry really offers accelerated programs of study. As Dympna suggested, it might attract more mature applicants who've done a lot of research and are very committed to the profession that they choose to study. So we're more likely to keep them in terms of retention within the workforce. So why now? The time is right to start to look at more innovative models of care, as we've spoken about today. Sláinte care is a real driver in terms of people receiving the right care in the right place at the right time, delivered by the right team. And a lot of our allied health professions are highly equipped to be within the ambulatory hubs in the chronic disease networks to be able to be that person and drive appropriate care for the patients and improve outcomes. We want to encourage people to stay healthy in their own homes and in communities for as long as possible. And again, allied health professions can play a unique role in helping to achieve that by working within the networks, within community specialist teams. And we've heard about the importance of teamwork and us working together more interprofessionally. COVID-19 is also another real driver. So we know that a lot of our allied health professions were redeployed during the COVID-19 pandemic. So many were taken away from their primary role, either working within COVID-19 testing centres or within call centres. Many services were pretty much decimated, and I'm thinking of my colleagues in speech and language therapy particularly, where there was significant redeployment of speech and language therapists. And as a mother of a child who requires speech and language therapy services, the problem that we're going to face now is not just the massive waiting lists of people who have gone back to their primary roles, but it's the delay in accessing services. For instance, that child who hasn't been able to access any speech and language therapy for the last 2 to 3 years, and the impact that that's going to have on the services as we move forward. So what are the barriers and enablers? Barriers to advanced practice. I think a lot of our allied health professions, and that's why I have this image here, we're working with our hands partly tied behind our back. We're really quite behind the curve in this country in terms of advanced practice and what allied health can really bring to the healthcare workforce. It's hierarchy to be overcome in the medical system, role definitions, evolution of responsibility, and then legislation, for instance, doesn't allow the likes of physiotherapists or podiatrists to access prescription-only medicines, unlike in other jurisdictions, including in Northern Ireland. Enablers then, we really need the support from healthcare management and leaders in the health service and in education to support new models of working, that workforce transformation, close collaboration and unity to drive that change and develop advanced roles and collaboratively contribute to the workforce transformation. So to conclude, health services continue to face these real considerable pressures. We've shown that we can respond in the height of a crisis, in the height of a pandemic, but we must now move forward and start to transform the way that we work with service provision and optimised standards of care. Advanced care practitioners, particularly in the health and social care professions, can make a real vital difference in terms of that workforce transformation and in terms of the delivery of new models of care. So graduate entry is something we should embrace and we should move forward with, and within the School of Health Sciences we'd be committed to starting to develop graduate entry programmes within our existing disciplines, but also we need to be open to the healthcare needs of the local region and what other programmes might we need to look at in terms of supporting the workforce in our region. We need to overcome those barriers and we need to work together collaboratively as healthcare leaders, as healthcare services, and as the University of Galway for the benefit of the patients who use the services within our region. Thank you.
Professor Caroline McIntosh. I'd like to introduce you now to Professor Dara Byrne. She's the Professor of